everyone. Welcome back to I Care for Your Brain with board-certified neuropsychologist Dr. Karen Sullivan. That is me. We are here to bring you high-quality brain health information and empowerment so you can be your own best advocate. Last lecture, we talked about Xanax, the good, the bad, and the ugly, and I made a promise to you that I would be back to give you important information about benzodiazepine use and the risk for dementia. So I am here today to make good on that promise. If you take a benzodiazepine like Xanax, this is need to know information. Even if you take it rarely, I still want you to understand what it is I have to tell you today. Xanax is also called alprazolam, and this is what we call a short-acting benzodiazepine. It comes on quick and it leaves quick when you think about it as one dose. It is very effective at relieving acute anxiety like happens in panic disorder, severe post-traumatic stress disorder, but the problem is because of that quick-acting nature, it has a high chance of becoming very dependent on it and developing a tolerance. We worry a lot about addiction with these short-acting benzodiazepines, which also include things like lorazepam, which is Ativan, or clonazepam, which is Klonopin. So as I said in my last lecture, I think there is a role for occasional low-dose benzodiazepine use in people who are highly anxious and traumatized. If you are severely sleep deprived, there may be a time and a place for you to take this medication under the direction of a medical provider. The concern, though, is when we start to take it every single day. The bigger concern is when we need higher and higher doses to get the same effect. That is a sign that you have built a physical tolerance. And that can happen in a much shorter time than you probably realize, as little as 1 month. Withdrawing from any type of benzo should be done under a very long and slow process in collaboration with your medical provider. So why am I focusing on this connection between Xanax and dementia? Well, benzos of all kinds, including Xanax, are widely prescribed to older adults, despite the fact that there's warnings from multiple professional organizations saying that we need to reduce their use, mostly because of falls, hip and arm fractures, and car accidents. So if you are an older adult over the age of 65, the risk of fracturing your hip within the first 2 weeks of taking Xanax, typically getting up to go to the bathroom at night, is high, okay? The risk increases with higher doses and when other centrally acting nervous system drugs are added. So if you've had a drink or if you take a painkiller like an opioid. Benzo prescriptions from primary care in women are nearly twice as common as they are in men. And guess who is at highest risk for developing dementia? Women over 65. And this is the population that is the focus of this research, people over the age of 65. So if that's you, I need you to listen. I don't know of any studies who have tracked people who use benzos in their 20s and 30s into their 70s to see if that increased the risk of dementia. But what I do know is in about 68 very high quality studies, so these are the gold standard approach, double-blind, placebo-controlled trials, benzos are consistently associated with cognitive impairment, including memory symptoms, with larger effect sizes in people who are over 65. So let's just pause for a minute and think about that word associated. So that just tells us these two things are related, okay? We don't have evidence of a cause and effect. This is a correlation. So they're just telling us as one thing goes up, so does something else, okay? The main concern with this body of research, though, is that the very conditions for which benzos might be taken, like depression, anxiety, post-traumatic stress, involve high cortisol, okay? And so these issues have been independently associated with the development of dementia when they occur at severe and sustained levels, mainly through the mechanism of constant cortisol excretion and high inflammation. We are just starting to understand the core role of high inflammation in all sorts of different brain conditions and mental health conditions. So in the early days of the studies looking at benzos and dementia, what we saw was a dose-dependent relationship. And what that meant was the longer someone took it, the worse they were, and the higher doses that they took the Xanax at, the worse they were in terms of developing cognitive impairment. And what we used to think was a cutoff was about 180 days of consistent use. So this is about 6 months of daily use. We also used to get worried that when people took it for at least a year, that we used to think the risk of dementia increased by about 50%. Now that's pretty startling, okay? And if you just Google this topic, that might be what you first find. And that is very scary. And that's why I want you here with me to get the science on this. So first thing is, again, this was just an association, okay? So think about it. You're a smart person, right? What else could be associated with these two things, the development of dementia and the use of benzodiazepines? So first thing, when I start saying words like dementia and cognitive impairment, the first thing I want to do is define those for you, because it can sound a little bit like jargon, which is something I don't like. We want to communicate as brain health doctors in the clearest possible way so you can actually understand what I'm saying and use this information in your everyday life. So let's just make sure we're all on the same page, okay? So as we age, there is a spectrum of cognitive change that will happen to your brain, just like you will see changes in your physical body. The first thing we have is what we call normal cognitive aging, and I'm going to define that in a minute. The next category is something we call mild cognitive impairment, or MCI, and that third category is dementia. So you will be somewhere, if you are lucky enough to live past 65, you will be in one of these three categories. So what is normal cognitive aging? Well, it is mild retrieval deficits. The biggest one we see is trouble coming up with people's names, actors, acquaintances, but you remain fully independent of everyday living tasks, okay? MCI means you have some more cognitive symptoms than we would expect just for age, but you remain independent with your instrumental activities of daily living, of which there are three: driving, medication management, remembering to take your meds when you should, the vast majority of the time. And the most sensitive area is complex money management, remembering to pay the bills, remembering your password to the bank, knowing how to write a check, these kind of things. Then we have dementia, the most concerning area, of course. Dementia is a very broad umbrella term, and underneath it there are a variety of brain diseases that cause the state of dementia. So dementia is significant cognitive decline in more than one area. So it might be attention, could be word finding, could be language, could be visuospatial. And these declines, these cognitive symptoms, are so significant that they need assistance in the driving, the remembering their meds, and the managing the money, okay? In all dementias, there are always three symptoms. There are the cognitive symptoms, the mood and behavior changes, and the impact on function. So someone has to have all three of those. So once you know you have dementia, the next job is, well, what type, right? No one just has dementia. There is reason or reasons that people have dementia, Alzheimer's disease being one of the most common. So now let's kind of map that onto how we think about Xanax. So the first thing I want you to know is that when anyone, no matter what age, takes a dose of Xanax, you are going to have cognitive symptoms when you're under the influence. And this happens at about the 1 milligram mark. So this can be in a single dose or actually cumulative over the course of one day. If you take enough benzos to reach 1 milligram, then you are going to have slower processing speed to the point that driving ability is impacted. That's why you'll see the warning on the bottle, don't drive. These effects are transient, meaning that once the medicine is totally out of your system, if you're an infrequent user, your cognition will return to the baseline it was before. What we're really focused on in this literature is the long-term use at these higher doses, okay? Recently, this body of literature took a little bit of a turn, and this is really the heart of what I want to tell you today. So the concern became, is there a potential bias in that data I referenced before that showed the association that is due to the lack of adjustment for what we call confounding variables? Some scientists call this the lurking variable. So this means something else is affecting the data, something else is going unacknowledged. So one example I read online about a statistical relationship that showed a correlation was that ice cream sales and drowning deaths per month happen just about at the same time every year. So you could erroneously conclude from that, wow, is there something about eating ice cream that makes people drown? No, obviously they just happen in the summertime. They have a relationship, but it's not an intrinsic cause and effect relationship. So in this field of study, what we're really focused on now, this is 2023, the cutting edge neuroscience talk, is the association between benzos and dementia caused by the very reason people take the medicine? Could be high levels of sleep disturbance, chronic anxiety. Is that what is actually driving the relationship to dementia? And the meds are just kind of a byproduct. Or is it that we're actually not treating anxiety in people over 65 or sleep disturbance in these people, but we're actually treating them for the earliest stages of dementia? So that's a totally different way of thinking about it. So this gets back to what we call prodromal dementia symptoms. So what this means is that we know that there are 2 time periods in the brain before someone is clinically diagnosed with dementia. So what I mean by that is before they are exhibiting the troublesome memory impairments that get them to a doctor. So brain-wise, I'm just going to take Alzheimer's as an example. The plaques and tangles that exist in the brain build up over time and actually take, I wonder how many years you think they're present in the brain before someone has a memory problem. Okay, write it in the comments if you're watching me. 20 to 30 years of buildup of accumulating damage. It has to get to a tipping point to where enough of the brain networks are damaged and die off that we actually start to see the clinical symptoms. Behavior-wise, once people actually start showing symptoms, it is up to 10 years before it may be noticeable to an outside person, or the person themselves starts to put 2 and 2 together and realize they're not remembering. The very first symptoms of many progressive dementias are not necessarily cognitive, they are behavioral. So the big ones, I'm going to again use Alzheimer's, are poor sleep quality, so fragmented sleep, a lack of a sleep-wake schedule, being up a lot at night, sleeping during the day, too much sleeping, episodes of agitation, and apathy. Apathy meaning someone loses interest in the things that they used to like. So this could be the very reason someone gets their first benzodiazepine prescription. Or is there something else? Maybe there's some other medicine that this group is taking that then is getting in the way of really understanding the relationship. So the very best quality studies I have read are inconsistent. 2 recent meta-analyses said, yes, we see that this association remains, but three other good quality studies said, no, we don't see the association. So the good researchers at the University of Michigan and the VA up there wanted to really unpack this question in a very smart way. So their question was, could one potential reason for this conflicting data be that they didn't account for other medication effects that are being seen in this community? And they specifically looked at a type of medications called anticholinergic medications. When used over weeks and months, can cause cognitive impairment that is significant to the point of dementia, okay? And sure enough, older adults are prescribed benzodiazepines, are also prescribed these anticholinergics. So what they did is they looked at some VA data over a 15-year period, so 2000 to 2015. And before I tell you what they concluded, let's define that term anticholinergic, okay? So anti means against or negative or less. And choline is a precursor molecule to a neurotransmitter called acetylcholine. You need acetylcholine for learning and memory, okay? And some of the dementia medications on the market today actually put more choline, hence more acetylcholine, into the brain. So anticholinergic, they are literally taking a chemical out of the brain that helps memory. So it's kind of like a pro-dementia medication, okay? So this this is very concerning because there's over 600 different drugs that contain these anticholinergic molecules. Some of them are over the counter, so Benadryl, Dramamine, anything with a PM. We also see different classes of drugs. Some antidepressants, Paxil is pretty high. Some, bladder relaxants, oxybutynin, Vesicare, muscle relaxants like Flexeril, some cardiac drugs like Lasix, Lopressor, even things like Zantac are high in anticholinergic. So how do you know if this is a problem? Well, I have developed a handout that I'm going to link in the comments that is totally free. And what you're going to do is rank every single pill you put in your body, and you're going to come up with what we call your anticholinergic burden score. So that cumulative impact of everything you take, you're going to come up with a number. You're going to see this. The handout has all the top anticholinergic meds and over the counters, and you're going to go through and customize it to you. And you're going to bring this to your doctor if it's a high number and concerning. You might also know because you are dry. Anticholinergics dry you out. You have dry eye, trouble peeing, heat intolerance, constipation, and mental slowness. When we look at a random sample of people over 65, 90% of them have detectable levels of anticholinergic drugs in their system. Oh my gosh. And what we know as advocates for brain health is that many people's complaints about these side effects just go under the heading of normal aging, which then also maybe leads to another prescription. And now we've got what we call polypharmacy problems on our hands. So the risk for cognitive impairment is increased by 50% in adults that take at least 3 mild anticholinergics for more than 90 days, and by 100% if you are receiving 1 or more severe anticholinergics for more than 60 days. That is mind-blowing. So that means if you are taking a drug that is high in anticholinergics, which you'll learn from our handout, for more than 60 days, you have a 100% chance of having cognitive impairment. Unbelievable. So we've tracked these folks over time, and after about 7 years, these people are more than 4 times likely to be diagnosed with dementia and have less brain matter in their memory areas. Holy smokes. Okay, so let's go back to the VA data. This was published in the Journal of Gerontology, and this was one of the largest studies to date. So they have a huge sample, about 528 veterans. The mean age is 77. Okay, so the first thing they found is that when you were prescribed a benzo, you had a 44% chance of also having anticholinergic medication in your medication list. So we've got a huge association there. When you statistically exclude the people who are just on a benzo, what you see is that there is no association between it and the development of dementia. And specifically, people with low benzo exposure had nearly identical the risk of developing dementia when we compared it against veterans who had a high history of using benzo. So that, we think, really argues against that cause and effect relationship because we don't see that dose-dependent incline as we plot the data points together. So what did the authors conclude from this? They basically said they think what people are really being treated for, if they start to take Xanax over 65, that it is those very early symptoms of a possible dementia that is developing. So they acknowledge that there are mild cognitive symptoms when you take a dose over the 1 milligram, but they don't think that there is a long-term risk from just benzos alone, and they want people to really look at these anticholinergics. The way I look at it is this is just one piece of a complicated puzzle, but one piece that I really want you to know so you can make better choices for your own brain health. The American Geriatric Society says please try not to use these drugs as what we call a first-line treatment for insomnia, agitation, anxiety, or delirium. Delirium is a state of confusion and agitation that often happens with hospitalization or a body infection, very commonly urinary tract infections. So first line means don't have that be the very first thing that you go to. Try other things first. Try changing the environment. Try looking at a medication list and reducing things instead of just adding things, right? I do really believe that at times some use of these medications is necessary, but I want you to aim for the lowest dose you need for the shortest amount of time, okay? Unless we are talking like catastrophic life trauma, like prisoner of war, you were kidnapped. I mean, there's certain nervous systems that are so fragile that the way some people can only achieve a quality of life is through consistent use. But you should then be educated about that risk to be more informed about your own personal decision. But for the vast majority of us, we have to understand some degree of anxiety is normal. We can have these medications in our toolbox for emergencies, but it's not something that you should be taking in every single day, please. There are safer alternatives that are just as effective for anxiety and sleep problems, like relaxation techniques, cognitive behavioral therapy, guided meditations, free on YouTube, supportive counseling, okay? If this issue concerns you, you need to discuss it with your medical provider, and I hope you have a collaborative partnership with them where these types of conversations would be acceptable and you have time to have them. My job is to give you accurate, objective information so you can be the very best advocate in that partnership. If you are concerned that maybe, oh my goodness, have I been thinking about my symptoms wrong? Are they anxiety? Maybe it could be dementia. I want you to advocate to see a person like me in your community, a neuropsychologist. Your primary care doctor, your neurologist should know about one of us that is local. If you can't find someone, you can direct message me and give me your zip code, and me or Carrie here on my staff, we will find you the best local provider, okay? We provide incredible, helpful, science-based brain health services, and you have a right to see one of us for a personal evaluation and personal recommendations. Please tell me what you think of this learning experience today. It's the only way I know if I'm on the right track. I really appreciate your feedback. Please subscribe to this channel, and most importantly, please share this information with someone who you think could benefit from it. Any of your social media groups is very, very helpful as we try to grow this message of self-advocacy and empowerment for brain health communities. Thank you guys so much, and I'll see you next time. Bye.